Good afternoon, everybody. I am Charlene Hudgens, the Executive Director of Benign Essential Blepharospasm Research Foundation, and I want to welcome you to the 2020 BEBRF webinar. We are so pleased to present this information for you, and we are also pleased to have you join us. Before we get started, just a few things of note. Many of the questions that you have submitted in advance have been embedded into the presentations of Drs. Murdoch and Soparker. If you have any other questions to ask, go to the Q&A function at the bottom of your screen if you are on a computer. Type in your question there, and if there is time at the end, we will address those questions. If we run out of time, the doctors will answer the questions in writing in the next newsletter, so you will get your answers. And so now, before we get started, and while we're giving more people time to sign on, I'm going to take just a few minutes to talk about the Blepharospasm Research Foundation. Hold on one second. Three-part mission. We research to find a cure, support because we care, and education to enlighten. Well, what does that exactly mean? Let's break it down a little bit. Research. Since the founding of the foundation, BEBRF has funded almost $3 million toward research to date. That includes a research project that discovered botulinum toxin as a therapy for blepharospasm. This research has been funded almost entirely by donations, and research grants are decided by physicians and researchers, most of them very renowned in their fields, on our medical advisory board. Support. We have a nationwide network of support groups. These support groups allow patients to interact with other patients, to share experiences and information. And now, since it's hard to meet in person, we have a Zoom support group meetings. This has the added benefit of helping people keep in touch. For people who have transportation issues going to support group meetings, they can join by Zoom. And there are areas in the United States that are remote and don't have a support group nearby, but those people can join in support group meetings as well. We also maintain a national database of treating physicians, so if you need to find a doctor to treat your blepharospasm, simply contact us and we'll help you find out. We also advocate for blepharospasm and its related disorder patients on both the national and local levels. We do this to ensure that research funds are awarded by the government to those entities that should be getting them, and to, in the case of any healthcare reform, that things like pre-existing conditions are honored and recognized. As far as education goes, we have an annual symposium, and this year, because of the pandemic, we're having a webinar. In fact, we're looking at maybe having more than one webinar. We also put out a quarterly newsletter, and out of that symposium, webinar, newsletter group, we are able to share a lot of valuable information with our patients, updates on what is new and what is latest, what people are doing to cope and get by, and so forth. We also have a vast collection of research, articles, brochures, and other materials that we keep and archive for anyone who may need them. And sometimes we do get calls from researchers. More often we'll get calls from patients looking for information on a variety of subjects. In addition, we have a website, and this website is filled with information that people can find easily. Even if the office is closed, there's information at hand for them to deal with their blepharospasm problems. And another issue that people don't think about is we attend national medical academies. Every branch of the medical field has what is called an academy every year. Neurologists, ophthalmologists, neuro-ophthalmologists, etc., all have academies where they meet once a year. Now, the average time used to be anywhere from 2 to 6 years to get a diagnosis for blepharospasm. Our attendance at these academies is designed to try and reduce that time frame, because even doctors in specialized fields are sometimes unaware of blepharospasm and unaware of its treatments. So this is why we attend the national academies, so that we can lessen diagnosis time and create bigger and better understanding among the medical profession of blepharospasm. So now it is time, I think. We have 159 people signed in. So I am going to introduce our speakers. First of all, I'm going to introduce Dr. Jennifer Murdoch, a native Houstonian who obtained her medical degree from University of Miami Miller School of Medicine. She completed her residency in ophthalmology at Baylor College of Medicine, and she followed that with a fellowship from the American Society of Ophthalmic, Plastic, and Reconstructive Surgery at Oregon Health and Science University. She is a board-certified ophthalmologist with a specialization in oculofacial plastic and reconstructive surgery, and she currently works for Plastic Eye Surgery Associates of Houston, along with Dr. Charles Soparker, who is a native of Massachusetts. Dr. Soparker received both his PhD in molecular biochemistry and his medical degree from the University of Massachusetts. He has trained, taught, and published in the fields of plastic and aesthetic surgery, oculoplastic surgery, molecular biochemistry, ocular pathology, ophthalmic oncology, and ocular and periocular aging. And he has been invited to lecture across 5 continents. Dr. Soparker has been a presenter at past BEBRF symposium, and he currently serves along the esteemed panel on our medical advisory board. One thing to note, Dr. Soparker believes that patient education is the cornerstone of successful care. I'm going to now pass the ball to Dr. Soparker.
Thank you, Charlene. Let me see if I can open this up here. Seems like I've disabled screen sharing. So maybe Charlene, you can address that. While you're doing that, I would like to say that I'm really excited to be able to talk with you folks today about blepharospasm. You know, Dr. Murdoch and I are surgeons, and so we don't get to see very many patients over and over again. The blepharospasm patients are among my favorite because I've been seeing them for decades. And so it's really pretty special to me. I do have to complain a little bit to the BEBRF. I thank them for inviting us, but you know, having lectured many times, I can tell you that the worst times to lecture in a symposium are the first lecture of the symposium, the last lecture of the symposium, and the first lecture right after lunch. And the BEBRF has assigned us all of those time slots in one. But we'll try to keep this exciting and eye-opening, all pun intended, for the blepharospasm patients. Let me see if it now allows me to screen share. It does. Okay. So let's open this up. All right. And let me see if I can shrink this down. Good. Okay. I think the most would agree that benign essential blepharospasm is not essential to their lives. They would find a way to survive if they don't have it. And I think it's not benign for many people. You're caught in the worlds between sighted and blind, and neither one or the other. So it's a constant struggle. Folks that are blind have an easier time than folks that come and go. And it's unpredictable. Sometimes it's painful, burning eyes, May syndrome that causes aches. Sometimes it is terrifying. You get very short of breath if you have spasmodic dysphonia as part of it. And so it can be very frightening. The good news is that nobody dies from blepharospasm. So even though you may feel short of breath, if you were to pass out, the blepharospasm and the asthmatic dysphonia disappear, and so nobody dies from blepharospasm. Most people attending these meetings are struggling. I'm trying to see how we can get rid of this here. Give me a quick second. There we go. Most people are attending these symposiums because they're struggling, and they're struggling psychologically. Why me? Why my loved one? Functionally, nothing is working well enough. I want better answers. And intellectually, I want to understand what is causing this blepharospasm. And it become overwhelming, fairly depressing. And right now, across the globe, there are other depressing things happening. Control is spiraling with this pandemic, and if you join blepharospasm pandemic, and we won't even talk about the election, it can be pretty overwhelming. So the theme of the lecture today is how to gain more control over managing your own blepharospasm. We want to give you more control. And perhaps through this, you can have a better perspective of your life and your blepharospasm. An important point here is that nobody will care as much about you as you care about yourself, not even your well-intentioned but busy physician. We all want a miracle cure for blepharospasm, and thankfully the BEBRF is working hard at trying to fund research projects, and hopefully we'll come up with one, but it's not here today, it's not here yet. And so we have to learn to maximize the tools that we already have. And that's what this lecture is about today. The second most important point here is that happiness is a choice. You can choose whether to be happy or not. And I hope that you will choose to be more happy. Knowledge is power. The more you know, the more you understand, and the more control you can have over your disorder. I'm really excited that we have Dr. Murdoch joining our practice, and we've asked Dr. Murdoch to review some of the fundamental basics today, and then I'm going to talk to you about how to use that knowledge to gain more control and better comfort with your blepharospasm. So she'll remind you of these essential basics, and we'll take those basics as seeds to grow into a better understanding and better control of your disorder. Dr. Murdoch, let me turn this off here.
Thank you, Dr. So Parker. And I'll share my screen for all of you. And get this going. As Dr. So Parker said, I'm going to go over the basics because, as always, knowledge is power. The more you know, the more you can contain control of this disease. We'll go through some of the anatomy, the eyelids, as well as tears, which are very important for this process. We'll review some pathophysiology, primarily the blink reflex. We'll see the differences between a normal blink and a blepharospasm blink. We'll learn a little bit more about the never-ending dry eye and blepharospasm cycle. And then we'll also do a short review of the various toxins, a medical treatment all of you are very familiar with. Let's first look at the eye and the eyelids. Peeling back the first layer, we see this is the muscle and the nerve components that primarily make up the issues with blepharospasm. First, we have the orbicularis oculi muscle. This is a circular muscle surrounding the eyelids, and it's responsible for contracting and squeezing the eyelids closed. This is the primary muscle that sort of takes control in blepharospasm. We have a few different parts to the orbicularis oculi muscle. So it's a very big muscle that composes the entire eyelid and area around the eye and causes a fierce contraction and closure. The frontalis muscle, we also want to note on this picture because it is an antagonist to all these closure muscles. This is the muscle in the forehead that actually lifts the eyelids up, and it comes into play as people with blepharospasm try to counteract their strong contraction and use this frontalis muscle to try to lift the eyes open. And while it might open the eyes a little bit more, we'll talk about how it also provides some further issues down the road. Now, importantly, are the nerves that innervate these muscles. The main one is your facial nerve. It's a cranial nerve, and it has a bunch of different branches. The zygomatic branch, the temporal branch, and the buccal branch are the main ones that innervate these muscles. Peeling back another layer, going a little bit deeper underneath the orbicularis oculi muscle, we have your procerus muscle and your corrugator supercilii. These muscles are in the brow, and that causes the strong contraction down that also pulls the eyelids closed and can contribute to the blepharospasm. Deeper, I wanted you guys just to see the elevation muscle is the levator palpebral muscle right here, and that lifts the eyelid up. So as you can see, it lies beneath these fat pads and is deeper within the eyelid, below the surface and beneath the orbicularis muscle. Now, looking at the eye again, we want to look at the surface. So let's take a look at tears and tear film anatomy. There are three components to tear film. The first is water layer. This is the powerhouse of the tear film. It's filled with all of the nutrients, proteins, healing elements, bacterial protectants, inflammatory cells. All of the good stuff lies within this water layer to carry the necessary nutrients and other goodies to the surface of the eye. The mucin layer permits even flow of the tears over the eye and adhesion of the tears to the eye. You want the tears to stick to the eye so they have time to provide those nutrients and all the goodies to the surface. And then we have the lipid layer. And this has a very important component in the eyelid, and that's the meibomian glands. And this can also affect both dry eye and blepharospasm. They're tiny little oil glands along the surface of the eye that can become diseased or can change with different inflammatory components affecting the eyelid. Now, the lipid layer is mainly the barrier, and it prevents the tears from evaporating off of the eyelid too quickly. It keeps that tear onto the eye itself, and also provides a good optical surface for the tears. Now let's look at the anatomy of the tearing. Your tears are produced, the aqueous portion, primarily in the lacrimal gland, and other glands that produce the mucin and the lipid components of the tears join the water component in the outer upper corner of the eyelid. They bathe across the eye to the nose, and this is supported by the way the blink works as well. And once it gets to across the eye down to the inner corner of the nose, we reach the tear drainage system or the nasolacrimal system. Everyone has two eyelid holes in the eyelid called puncta that drain the tears down into a tube system, first the canaliculi, which meet together to form the nasolacrimal sac, where the tears eventually flow out the nasolacrimal duct and exit to the nose. Now, this just shows that there are muscular components surrounding this nasolacrimal tear drainage system that support the flow of tears out of the eye and into the nose. So when we have spastic contractions and abnormal contractions of the eyelids that affect this contraction, pushing the tears down the system, it can also affect how the tears drain. Now, why are tears so important? First, they bathe and they protect the surface cells of the cornea. We want to lubricate and make sure the surface is nice and moist and full of nutrients. They also bring essential nutrients to the surface cells of the eye, and they take away the metabolic waste. So they are not only your restaurant server, but they're also waste management. They also bring important immune cells and factors to fight off bacteria, viruses, and other irritants, protecting against disease. Your inflammatory cells come with the tears to protect the eye against problems. They also maintain clarity of vision. And this can get a little bit complicated as we talk about optics and refraction and how light is refracted off the tear film to be refracted towards the eye and focused onto the retina. We won't get into all of that. However, it's important to know that the eye is designed to see through a cornea, water, and air system. You need those three components to have clear vision. Now, when you have cornea and water, but no air, everything is blurry. It's out of focus. The optics aren't quite right. And this is similar to how when you open your eyes in water, you can't really see much. However, if you wear a mask underwater, you retain that air-water cornea system, and you can see much more clearly. Now, when you have no tears, you lose the water component to this system. And again, everything is blurry. So when you have problems with dry eye, that's when we see this issue. Think of your eye as a ball in a basin of water. Tear production bathes this eye, and then your tear outflow creates a nice balance so that you maintain an appropriate amount of tears on the eye. Not too much, not too little. Now, as the tears flow across the eye, down into the nasolacrimal sac, this should maintain the balance. When you have dry eye, that's when this balance becomes disrupted. Your eye compensates with a reflex that initiates production of more tears, and this results in dry eye tearing or reflex tearing. So even though your eyes are dry and you're not having enough tears on them, you have tears streaming down your face because your body is trying to compensate by producing too many tears. Now, who is at risk for this tear film problem? Most of us. There are so many different things that can affect the tear film. First, increasing environmental pollutants and irritants. Outside wind, environmental allergies can cause issues with the tear film. Decreasing androgen to estrogen ratio, change in hormones. When patients undergo hormonal changes, especially such as menopause, you can notice that your tear film is disrupted and dry eye becomes more common. Tear gland demise over time, blepharitis. Blepharitis is this ocular irritation and crusting of the eyelids. Meibomian gland dysfunction, when your meibomian glands become clogged and oily and they're not secreting a nice smooth oil for your tear film. Ocular rosacea can cause a constant inflammation around the eyelids. All of this can irritate the eyelids and cause inappropriate tear film to develop. Increasing frequency of autoimmune diseases. More and more of these autoimmune diseases are being discovered and coming into light. And with any inflammatory process, your irritation around the eyes can lead to a disruption in tear film. Medications. More than 30% of all medications causes a decrease in tear production. Chemotherapy regimens also destroy tear glands. Let's look at these medications. Systemic medications. Very common medications can disrupt tear film. Blood pressure medications, cholesterol, anticholinergics, antidepressants, heart rhythm stabilizing agents or antiarrhythmics, Parkinson's disease agents, antihistamines, your common medications that you take for allergies every day, and many, many others. And then we have topicals as well. Not only do most topical drops for glaucoma, for corneal edema, and other issues, but also the preservatives that are seen in your regular tear supplements can cause problems with your tear film with continued use over time. Now let's look at blinking. Here we have a slow motion, normal blink, very slow motion. As you can see, a normal blink starts in the outer corner and travels towards the nose. This helps to bathe the cornea in the tears that we see so that the cornea can receive all the tears and the tears can exit towards the nose. A normal blink is about 12 blinks per minute. It takes about a third of a second. Temporal asymmetry, as I'm talking about, outside to inside. There's a faster closing and a slower opening in a normal blink. There are 3 different types of blinks. We have a spontaneous blink, which is periodic and involuntary. We don't have to think about it. We have a voluntary blink, which can be intentional. If we want to blink, we can close our eyes and open them. That's voluntary. But then we also have a reflex blink, and this is triggered by loud noise, bright lights, or a sudden impulse. And we can't control that. It's just a natural reflex that we have. So again, looking at this video one more time, knowing what we know about blink, we focus and we look at out to in and the way that a normal blink goes across the eyelids. Why do we blink? Again, lubricate the cornea. It's kind of a reverse windshield wiper. Not only do we don't want to wipe off the tears, we wipe the tears across the eye so that the cornea can receive the necessary nutrients. It clears debris from vision. Think about, you get something in your eye, automatically you start trying to blink it away. That's your natural response to try to clear this debris out of the eye. And it activates tear production from multiple glands. The muscles in the eyelids squeeze and helps push the necessary mucin, lipids, nutrients from the glands into the tear film. Now let's try to understand benign essential blepharospasm and what's different. In a blepharospasm patient, it's a little bit different. You lose the temporal asymmetry. So instead of it going from out to in, it's pretty much a flat blink across the entire eye. You don't have a good wave of tears going across the eye. So you don't have that good movement of tear film, nor do you have a very good pump to pump tears out of the eye either. It's spastic, it's irregular. It obviously happens at a higher frequency, but also at an inappropriate wave. It's uniform in one movement. Now, as we said, blepharospasm and dry eye go hand in hand. Looking at our model for tearing, as we said, we want to have that appropriate balance of tear production and tear outflow. Now, in normal people, when there's too little production or too rapid outflow, normal people have the compensatory production to create more tears to compensate for dry eye. Blepharospasm patients don't seem to have this response. So when there is dry eye, you don't produce extra tears to compensate for it. So we have a problem with the dry eye response. Now, dry eye and blepharospasm. In a normal eye, you have an irritant. When it touches the eye, you have a couple blinks to try to get rid of that irritant, to respond to that irritant, and then it stops. In blepharospasm, when we receive that irritant, we receive a couple of blinks, and then it keeps going, and the blinking does not stop. Looking closer. This is all a response triggered in the brain that we don't even think about. So when we receive an irritant to the eye, your brain says blink, but blink a couple times, get it out, and stop blinking. That's the normal response. In blepharospasm patients, an irritant triggers the brain to say blink. And these irritants can be anything from allergens, pollutants, toxins, breeze and strong wind, bright glare, eyelashes in the eye, wrong specs, and dry eye. However, your brain never signals that response to stop blinking. So the blepharospasm continues. There's constant blinking. And we're unable to stop this vicious cycle. Dry eye is the irritant that causes blepharospasm, causes blinking and irritation. Constant blinking affects dry eye because you don't have appropriate tears bathing the eye, and it causes further irritation. You perturb the blink. In blepharospasm patients, you have additional components. Botulinum toxins can cause incomplete blink. As the muscle is weakened to control the spasm, your blink response is not quite as full. There's also eyelid inflammation. This can cause tear stasis and poor quality in tears, as well as poor mobilization of the tear film, like we talked about before. This altogether is known as toxic tear syndrome, where your tears are not appropriately doing their job for the eye. They're actually causing more and more irritation to the eye. And then we also have frontalis antagonist blink syndrome. Remember that frontalis muscle we went over, that forehead muscle before. A lot of blepharospasm patients use it to lift up the eyelids because they're trying to counteract that squeezing of the orbicularis muscle. The forced effort to keep the eyes open results in a decreased blink and exacerbates the dry eye problem. Lifting up the eyelids too much, your eyes are too open, your tears evaporate off the eyes, and it is a perpetual cycle. How do you know if you have a tear film problem? The topical anesthetic test might make it easy to tell. This is the general paradigm. Irritation or dry eye to a normal eye causes inflammation. There is a response trying to promote clearance of the irritant. So it releases inflammatory cells to try to get rid of dry eye, to try to get rid of the irritants that are causing it. But in blepharospasm, this can create a continuous cycle. As you produce more inflammation, that can itself irritate the eye, which causes more inflammatory components to be produced, which causes more irritation problems. This irritation then signals your brain to blink more. The blinking causes irritation. The irritation causes inflammatory components to be produced from the eye. The inflammation causes irritation to the brain to blink more. And as you can see, the inflammatory cycle causes the eye to go haywire. Your brain is causing constant blinking. Everything goes haywire, and this is the problem in blepharospasm. The number one issue in this entire cycle is the irritation, the dry eye issue. And Dr. Parker will go through how to gain control over this dry eye horrible cycle. Now, let's move on to the truth about toxins. The bottom line on botulinum. We have many different toxins out on the market now. 6 different ones. Daxi is the 6th that is coming up soon. Let's go through the basis of toxins and how it works. Toxins come from a bacteria called Clostridium botulinum. It's in the Clostridium family of bacteria. The Clostridium botulinum makes a botulinum toxin. Why? For survival and domination of the bacteria. The botulinum toxins kill vertebrates, digest enzymes, produces chitinases to digest different proteinaceous materials, and Butysin, which kills competing bacteria. So it's trying to survive these certain bacteria. It makes 8 different toxins. Most of us are familiar with the botulinum toxin type A, which is in fact the most potent of the toxins. However, it is very fragile. Temperature, agitation, various enzymes can break down this toxin quite easily. Now, toxins we are familiar with are quantified in units. What is a unit? A unit defined as an LD50, or how much toxin it takes to kill 50% of Mickey Mouse. So, say we have all of these Mickey mice. Here, how much botulinum toxin will it take to kill 50% of them? That is equivalent to 1 unit. So 1 unit of Botox is 1 unit of Botox. It is the standard. And that's what we consider a unit. 1 unit of Xeomin is 1 unit of Botox. 1 unit of Jeuveau is 1 unit of Botox. 2.5 to 3.5 units of Dysport are equal to 1 unit of Botox. 45 to 55 units of Myoblocks are equal to 1 unit of Botox. It all comes down to potency. Now, botulinum toxin can be very deadly. However, a lethal dose of Botox is 28,000 to 2,800 to 3,500 units. This will never be reached in the amount of toxin that is injected. Another important component to botulinum toxin is the charged polypeptides. Now, these polypeptides allow the toxin to stick to itself, the molecules to stick to each other, and also stick to the glass. One of the important carrier proteins that aids these polypeptides and adhesions is human serum albumin, and that is seen in many of our toxins. So looking at the polypeptide, I'm just going to show you, it basically is composed of 2 different components, a heavy component and a heavy and a light chain. So a non-hemagglutinin component and a hemagglutinin component. And each toxin has its own makeup, so to say. Botox, the standard, which most of us are familiar with, is a single-strand pre-processed protein. It is comprised of both hemagglutinin and non-hemagglutinin carriers or proteins. It has the HSA carrier that promotes adhesion to each other and the glass. The market advantages is the original, right? Everyone knows Botox. Xeomin is the other one that a lot of us are familiar with in terms of medical treatment. It is also a single-strand pre-processed protein. It does not have any of the carrier or any of the other proteins attached to it, so it is marketed as the most pure protein. Jeuveau, or Nutox, which is primarily used for cosmetic purposes on the market right now, is the highest tech protein or highest tech toxin, and it's made in the USA. Dysport is a mixed partially processed toxin. It also has the hemagglutinin, non-hemagglutinin, and HSA on it. It's supposed to work faster, spreads better, and is smoother. Now, Myoblocks is different than your other toxins because it is a type B toxin. It is a pre-processed protein as well that is has hemagglutinin, non-hemagglutinin, and also carries the HSA. Myoblocks is supposed to work within 12 hours, so it's very rapid, has a very rapid onset. Daxi is the newest one on the market. It has a secret protein, a proprietary protein called RTP004. It does not have any HSA, so they're marketing it without any human serum albumin, and it's supposed to last twice as long. We'll look into the studies that show that in a bit. So let's just show, this just shows you the different components of the different toxins. Basically, they're all very similar. is what we're trying to show here. There are a couple different variations that might make it last longer, diffuse wider, has to do with how the proteins cause different interactions to the different molecules and binding to each other. As I spoke about before, there's a heavy chain and a light chain to botulinum toxin type A. Very importantly, and Dr. Stoparker will talk about this a little bit more later, is the zinc binding metalloproteinase that Botox needs to perform its duties within the cell. Zinc is very important. Now, this light and heavy chain is bound by a disulfide bond to keep it together. Now, the toxin goes into the syringe. Now, what happens when it is injected into the muscle? In a normal muscle, we have anticholinesterase, which causes SNAP25 to stimulate contraction of muscle fibers. When the botulinum toxin is injected into the muscle, we have cleavage of the SNAP25 protein, and therefore it prohibits the muscle fibers from contracting. And again, zinc is needed for this interaction of botulinum toxin with the SNAP25. So disruption of zinc or an abscess of zinc will make your botulinum toxin not work quite as well. Now, targets for the toxin. Looking at your anatomy before, our main targets are these strong contracting muscles around the eyelids. So first, we target the orbicularis oculi, mainly that pretarsal palpebral portion. Next, we look at the more orbital portion of the orbicularis oculi. So we want to target right around the eyelids, but we also want to get the full circumference of that contracting orbicularis and make sure that we weaken all of the muscles that cause contraction. And lastly, we want to focus on those brow muscles. Like we talked about before, the procerus and the corrugator muscles underneath the brow also help to contract and squeeze the eyelid muscles closed. So these are our targets when we look at toxin for the treatment of blepharospasm. Now let's just touch on DAXI as a last little tidbit on toxins today. Daxibotulinum toxin A is the newest toxin that is coming on the market. It is also 150 kilodalton botulinum toxin. It has this proprietary stabilizing peptide, a secret peptide that is highly positively charged at a physiologic pH, meaning it promotes strong binding for certain molecules. There is no human serum albumin involved in this particular type of toxin, and it's stable at room temperature. Now, the trials that the company put through, Sakura 1 and Sakura 2, are the phase 3 clinical trials needed for FDA approval. They were used on glabellar lines, not on blepharospasm. They used 40 units in the glabella, and that seemed to be better than 20 or 60 units in these studies. And the efficacy was maintained for 24 weeks. So this is important because this shows that this toxin has the potential to last longer than studies have shown for other type A toxins in the past. Let's see what happens with it. Now, what can we do now that you know all of your basics? How are we going to take control and manage all of the problems associated with blepharospasm? So, Charlie, Dr. Stoparker, I'm going to send it back to you.
Thank you, Jennifer. That was great. And we're going to use all of that information here in just a second. Let's see. See if I can get this to share. Here we are. Let's see. It doesn't seem to want me to share. Let me try to technology, right? Let's try this again. Here we are. Okay, so here's a cartoon, and it shows a lifeguard sitting in his tower and somebody drowning out in the water. And he says to them, if I toss the ring to you, you'll just become dependent on it. What we want to do is we want to give you the power to have your own rings. So don't wait for somebody else to help you. Let's talk about what you can do, and it really comes down to two things. One is things you can do to help yourself, and the other is things you can do to help your doctor to help you. Dr. Murdoch talked about two important concepts. The first was that dry eye and blepharospasm are interlinked. One causes the other, and you get into this perpetuating problem where once you get started, it just keeps getting worse. The second is this model here, where any irritant to the eye causes the brain to say blink, and then once you've blinked, you stop blinking. With blepharospasm, as she said, it interrupts that process where the brain says stop blinking. And I call this neural misfunction, and I call it that way for a reason. What's that?
It's not sharing yet.
It's not sharing? Let me see.
Go back to the main Zoom.
Let's see. Rio just told me it's not sharing.
Right here. Okay, go there. Okay. Now what you will do is share screen.
I tried that.
Okay, and then click which one. Okay, and then share.
Let's see if it's working. Okay, let's see if that's sharing. Can you see if that's sharing now, Rio? I'm so sorry, folks. Okay, so we talked about the dry eye, blepharospasm, and we talked about this general paradigm. And in blepharospasm, that stop blinking is interrupted, and I call that neural misfunction. And it's important to think about it this way. It's not a malfunction. A malfunction is a function failure. A dysfunction is a process problem that causes malfunction. So I think about it as the piston is dysfunctioning in the engine of a car, and then the car malfunctions. This is a misfunction. Something else happens that we didn't expect to happen. So this is not a disease. It's not something bad. It is a miswiring and miscommunication within the brain. So we put these 2 points together, as Dr. Murdoch did, that various irritants cause eye inflammation, and the eye inflammation mediated chemicals then cause more dry eye and irritation. And this causes the brain to say blink, and you have this neural misfunction. And there are 4 approaches to managing blepharospasm, and it works on this model. So these 4 points are what we're going to talk about, changing these 4 parts of the process. The first is the getting rid of the irritants, the dry eye. So when we think about the irritants, we think about mechanical irritants, entropion. If your eyelid is turned in, it is rubbing on the eyeball. And it's not just the lashes, it is the skin. The skin is very rough, and that can certainly cause blepharospasm. And often with blepharospasm, there's muscle overaction that causes the eyelids to turn in. Trichiasis and distichiasis are the eyelashes rubbing on the eyeball. On the left side here, we have trichiasis, where the eyelashes are misdirected. And on the right side, we have something called distichiasis. And if you look carefully, the eyelashes are growing out of an oil gland the oil gland is turned into an eyelash follicle. And that happens with chronic inflammation. It's kind of bizarre. It's like saying an arm turns into a leg, but that's actually what happens. With ectropy, and the eyelid is turned out, and the eyelid mucous membrane becomes more like skin. And when you blink, that rubs up against the eye, and that's very irritating as well. On the right side, we show how rough regular skin is, and on the left side, we show how smooth mucous membrane is. We've talked a little bit about dry eye management, and I really want to spend quite a bit of time talking about that. Again, you want to solve any mechanical problems like upper or lower eyelid retraction. You can see in this patient here, there's a lot of distance between the colored part of the eye, the iris or the cornea, and the lower lid, all that white showing underneath. We don't want that. The greater the distance between the upper and lower eyelid, the more surface area there is for the tears to evaporate away, and the more dry eye problem there is. So we want to correct those surgical issues. Dr. Murdoch talked about frontalis antagonist blink syndrome. This will often happen if the eyelids are droopy, so-called ptosis, so the eyelid is droopy anyway, or there is brow ptosis, the brow is droopy. You want to correct those problems first. Lag ophthalmos is where the muscles don't work well enough, and so the eyelid doesn't close properly. And there are many ways that we can treat that. One of the ways that you'll hear about a lot are these gold weights that are implanted into the eyelid to put more weight in it to help the eyelids close better. So we want to solve all these mechanical problems first. Then we want to address tear layer problems. And Dr. Murdoch very clearly explained the different layers of the tear film and explained how all three of these layers are produced by different types of glands. And all of them can be destroyed by inflammation. And we're going to talk about all three layers and how you can manage treatment of dry eye or irritating tears by managing these different layers. So the mucin layer problems, and I have to say for those of you who are biochemists in the audience, that mucin lipid biochemistry is fairly complex, but we're going to oversimplify it here. Let's say you have too little mucin. I explain this to people that it's like having Vaseline on a surface and now you splash water at it. It just won't stick. So if you don't have mucin, the tears won't adhere to the surface of the eye, and that's a real problem. Then you don't have lubrication. This is common in vitamin A deficiency. And anytime you have severe scarring of the eye surface, the mucin-producing glands are within the mucous membrane that lines the eyelids and the eyeball. And so if you have chronic severe inflammation of the mucous membranes, then you will destroy those glands and you will have a mucin deficiency. Mucin deficiency is treated with very special kind of eye drops. These are drops that may contain trehalose or hyaluronic acid. And again, these are not the typical lubricating drops that you might put in. These are special eye drops. What if you have too much mucin? That's a problem too. And you'll notice that because you'll have these thick mucus ropey strands in your tear film. You might wake up with them or get them throughout the day. Treatment of this is usually very effectively managed with N-acetylcysteine. You get this over the counter at a nature food store. You take about 600 milligrams a day. Check with your heart doctor first because it can affect the thinning of your blood. It can make your blood more thin. Also, you want to be careful because it can cause a number of GI problems. But that's a very effective way to treat too much mucin. And too much mucin may come from inflammation on the surface of the eye. So you may want to do measures to cut down inflammation, steroids, and other drops that we'll talk about later. So that's the mucin problems. Now let's talk about the water or aqueous layer problems. Again, this is an oversimplification of the complex biochemistry involved. Please forgive me if you are a biochemist. Tear supplements that are used to replace the aqueous component are not designed to take the red out. If you read the drop and it says takes the red out, don't use it. You're talking to the person who wrote the paper, 70 patients blinded by using drops on a regular basis that take the red out. What those drops do is they cause a vasoconstriction. The blood vessels get smaller, and your body becomes physiologically dependent on that. When the tissues don't get enough blood and oxygen, they release other chemicals that say, hey, give me more blood, give me more oxygen. And so they cause a rebound vasodilation, or they cause the blood vessels to get bigger. And the patient says, oh boy, I need more of these. Let me put more of these drops in my eye. And it gets into a vicious cycle of using more and more of these drops until you begin to cause severe low oxygen to the tissues. So don't use the drops that take the red out. We're not talking about allergy drops either. These are lubricating drops. Allergy drops you use specifically for situations where you have eye allergies, and you would know because you have eye itching. Itching is the hallmark of allergy. So if you need an antihistamine drop, your doctor will prescribe it for you, but don't use them as a lubricant. They will cause more eye drying. Don't use an eye rinse or an eye wash as a lubricant. These are good if you have toxic tear syndrome, which Dr. Murdoch mentioned before, where you have lipids in the tear film that are not being mobilized. They oxidize, become irritating to your eyes, so you develop a problem to your own tears. For those of you who cook, you know that if you take olive oil and you put it in the pantry for 6 months, when you take it out, it's not quite the same. It oxidizes, becomes exposed to oxygen in the air, and becomes rancid. So rancid tears are irritating to the eye. You can rinse those out with a tear rinse, but that's not a lubricating drop. Most of the drops on the market are complex tear supplements. They're made to somewhat bind to the eye and have a number of different nutrients in them. And there's a lot of them that are out there. And the lubricating base is quite different in the different drops. If you want to know a lot more about these, on our website, plasticeyesurgery.com, we have something we wrote called Mastering Tear Supplements, and it will help to sort these different things out. Important point here is that I can't always predict which type of drop will be the most beneficial for a particular person. A dry eye specialist can help you with that better. Remember, there are 9 different specialties in ophthalmology, and there are subspecialists among those specialists. So, for example, an anterior segment specialist, that's one kind of an ophthalmologist. There will be a subspecialty within the anterior segment people who specialize in dry eye management, and they should help to be able to recognize what components of your tear film are problematic and which of these drops would be most beneficial for you. And you can be creative. These different drops come with different concentrations of these bases. For example, oil. The more oil you have, the longer the drop will last, but the more it will blur your vision. Also, you can combine these. You can take the cellulose base and the oil base and use both of them together if you find that most beneficial. Really and truly, you are the one who's going to be able to tell us best which drop works the best for you. And I want to remind you about these lacrocerts or the hydroxypropyl cellulose inserts that can provide a slow release of drops into the eye. Many lifestyle changes can help you to keep your eye better lubricated. Increase humidity. You can get a humidifier that you keep in your room that can help to keep your eye moist. Avoid wind, dry heat, high altitudes, smog, smoke, exhaust from vehicles, prolonged reading or computer use, soft contact lens wear. Why? All these things. Most of these things that I've mentioned will increase the rate of evaporation of the tears off the eye. If you do prolonged concentration, reading, driving, watching television, working on the computer, your blink rate drops. Dr. Murdoch told you that normally we blink 12 to 20 times a minute. When you're concentrating, your blink rate drops to about 5 times a minute. So if you're going to sit and read, think carefully about doing a more frequent slow blink. I often tell my blepharospasm patients, when you feel the spasming coming, try to relax into the blink rather than trying to fight it. Eye shields or goggles help to decrease the evaporation. And then there are tear conservation methods. Punctal occlusion. Dr. Murdoch explained to you here how the tears wash across the eye and come down to the canaliculi, or these draining systems. And so if you have a good quality tear, you can block up one or both of these tear drains and keep more tears on the eye. You want to be sure that you do not have bad quality tear before you close these off, because if you have toxic tear, it's going to keep those bad tears on the eye even more. There are things we can do to decrease the surface area of the eye to evaporation. You can sew the eye partially closed, something called a tarsorrhaphy. You can drop the lower eyelids down. You can raise the lower eyelids up, decrease the surface area of the eye that's available for the tears to evaporate away. There is a myriad of moisture chamber goggles that are available on the internet. Amazon carries many of these. These are very helpful in keeping moisture on the eye, especially at night. They have a lot of these that have foam. If it is permeable to air, it's not quite as good as the ones that are probably hard rubber gaskets around the goggles to keep the moisture on the eye. Even swimming goggles work just fine. Some patients like to use press and seal. This is dirt cheap. You can get it, cut it into little squares, stick it on the eye at night or with the closed eye, and it will provide a moisture chamber. If you really want to get fancy, you can put some Vaseline on the eye first and then put the saran wrap or press and seal. Vaseline comes in a tub and it comes in a tube. It also comes in a very small tube for lip balm. If you get the tube, you put it in a mug of hot tap water for 30 seconds, and it will be runny, or the little Vaseline tube that you'd use for lip balm, you can hold it in your hand for 10 seconds and it's runny, smear it on your finger, put it on your eye. It blurs the vision quite a bit at night. You might have to rinse it out in the morning, but it's very effective in keeping your eye lubricated at night. For those who have not heard of the scleral lenses, the original one was the Prose lens, the Boston scleral lens. They've renamed it the Prose lens because now it's a prosthetic, and insurance companies will often pay for a prosthetic, not for a contact lens. The Prose lens are custom made for your eye. They tend to be fairly expensive, about $8,500 a piece. There are other scleral lenses that are available off the shelf, and these run about $400. And they are really big lenses that have a fluid reservoir in them. So you put some fluid in it, you slop it on the eye, and it bathes the eye all day long. And you can talk to your doctor about whether you'd be a good candidate for that. The last layer we're going to talk about is the lipid layer. As Dr. Murdoch explained to you, the lipid layer is produced by the meibomian glands in the eyelid. And when these meibomian glands become plugged up, you get what's called posterior lid margin disease, a kind of blepharitis, or a meibomitis. And again, what happens is this oil sits in the eyelid, it oxidizes, becomes inflammatory, and then you have toxic tear syndrome, or you don't get the oil component into the tears. And it can look like this. Dr. Murdoch showed you the slide before, all the oil kind of pouting but not coming into the tear film. And if you look carefully, you'll see that there's one where there's kind of a worm-looking structure there. That's where it's been squeezed hard and it's come out more like toothpaste than oil. So there are three reasons why you get this posterior lid margin disease problem. Either the oil that you're producing is too thick, the opening for the oil to come out into the tear film is too small, or the opening is clogged. And so we'll look at these three things and what you can do about it. If the oil is too thick, you can take these oils by mouth, and over 3 to 4 weeks, it will thin the oil that you produce. Typically, it's omega-3 oils, flaxseed oil, or borage oils, or all three. They're synergistic together, and you have to take them with a sulfonated protein. The sulfonated proteins are egg, turkey, soy, peanut butter, and fish. Egg is the best of these. So if you take the oils without these sulfonated proteins, you only absorb about 1/5 of what you could normally absorb, and it passes right through into the toilet. So if you're going to take these oils, you want to take them with a sulfonated protein at the same time. Flaxseed oil should not be taken in a capsule. The omega-3 and the borage oils can be. The reason is that flaxseed is more, it degrades the capsule. And so they make a thicker capsule so it has a longer shelf life. By the time that capsule breaks down, it's passed through the small intestine, and so you can't absorb it. So you want to take the actual oil if you're taking flaxseed oil. The flaxseed coat is a phytoestrogen. That means that it is a plant that looks like an estrogen to the body. So men may want to avoid taking the actual ground seed, and women who have breast cancer may want to avoid the ground seed and just take the oil. Hot compresses are a mainstay for managing thick oil posterior lid margin disease. There are a bunch of ways that you can do this. Probably the easiest way is to take raw rice, put it in a sock, microwave it, take that, put it over your eyes, over a hot, wet face cloth or paper towel. The rice acts as a heat source to keep the paper towel or the face cloth hot longer. And what that does is it melts the oil. LipiFlow is a system that you can get from your eye doctor that will tend to melt these oils as well. And if you've got a very severe problem, they can inject your eyelid with local anesthetics and then squeeze out the oil. It's a little bit problematic because that technique creates some inflammation in itself, but for really inspissated or constipated oil glands, sometimes you have to do that. Doxycycline, which is an antibiotic taken by mouth, this will thin the oils. It's a little bit of a problem because it is an antibiotic and it will change the bacterial flora if you're taking it on a regular basis. But sometimes we use it to thin the oil as well. If your opening is too small, what do? Well, we typically will give you some corticosteroids or steroids topically for a short period of time, decreases the eyelid inflammation, and may allow those pores to open up a little bit more. Sometimes the openings are actually clogged, and the thing that most commonly clogs these is an overgrowth of staph bacteria. So sometimes we will give an antibiotic topically, either an ointment or a drop, to try to knock down the bacterial load. Doing eyelid scrubs in this particular kind of situation is a two-edged sword. You have to do it correctly. Doing scrubs will knock down the bacterial growth, but if you do it too rigorously, it'll cause inflammation of the eyelid and cause the gland openings to be even smaller. So you have to learn to do it gently to knock down the bacteria without creating inflammation in the eyelid. Okay, so these are the things that we do to decrease the irritants to the eye. Now let's talk about what do you do to decrease the inflammation that may happen here. Decreasing the inflammatory response is typically done with a number of different techniques. One is azicite, which is an antibiotic that also has an anti-inflammatory action. You would continue to use it for the anti-inflammatory action. Remember, any antibiotic that you put in your eye, after about 7 days, the bacteria that are there will develop resistance. You can't keep eradicating bacteria. The bacteria come from your skin and other sources, and if you continue to use an antibiotic, you will just develop resistant bacteria. But azicite also has an anti-inflammatory action. There are a number of non-steroidal drops that are all prescription that your doctor may prescribe to cut down inflammation without going to the stronger corticosteroids or steroid drops. These tend to be less problematic. The corticosteroid drops increase the intraocular pressure in the eye with long-term use, which means they can cause glaucoma, and they can also cause cataracts. There are some drops which stay more on the surface of the eye, don't get into the eye to increase the risks of glaucoma and cataracts as much, but these tend to be quite expensive. If you get prescribed one of these drops, I would strongly recommend that you go on the internet, and you will find that if you find the manufacturer of that drop, typically they will have a coupon on their website that allows you to get those drops a little bit cheaper. Restasis, which is cyclosporin, which is chemotherapy, is often prescribed to patients. We have a lot of experience with what cyclosporin does taken by mouth, taken by vein intravenously or endonasally. Remember, everything you put in your eye, you swallow. The newer anti-inflammatory drop, Zidra, we have really no experience with that in other systems. It's not commonly used as a chemotherapy, so I'm not really sure what the potential side effects of that will be. It's like a drug that we do use in other situations, and that drug can have long-term neurologic and problems with the white blood cells, which can increase your risk of infection, but I don't know that Zidra does those things. Okay. Now I'm going to talk about things that are anti-inflammatory that you could take in your diet. And some people may think this is witchcraft. There's some science behind it, and some of this is alternative medicine. We have a lot of experience with patients changing their diet for thyroid eye disease, which is another very inflammatory disorder. Some patients who have severe thyroid eye disease change their diet, do some of these things, and the disease suddenly stops. Unbelievable. I have a lot of other patients that tell me that they do these dietary things and it makes no difference. And I don't know whether they really don't do these dietary things or whether there's so many different factors that have to be aligned in order for the diet to make a difference. But I'll throw these out there for you to think about. And as you're thinking about how crazy I'm talking about these different things, think about how many of you have tried willow bark extract. Willow bark extract is aspirin, and most of you have done that. So as we talk about these different things you might change in your diet, keep an open mind. There's a lot of data about gluten being very inflammatory, and more people are getting to an anti-inflammatory diet that is gluten-free, vegan. That's a very hard diet to keep. And if you're going to try to do something like that, I would strongly encourage you to speak to a dietitian or a nutritionist, because you want to make sure you keep all your regular vitamins going. That may be vitamin supplementation, but be careful about being too radical in your dietary change. But avoiding gluten, we believe that gluten creates some inflammation in some people's guts, which allow bacteria to translocate into the blood, which creates inflammation and can cause inflammation throughout the whole body. Minimize dairy, food containing casein. A lot of people believe that beets are really good for decreasing inflammation. Unfortunately, the betalains that are in beets are very sensitive to heat. And so if you overcook your beets, you will destroy the benefit of the betalains. Brightly colored fruits and vegetables are good for anti-inflammatory properties. Blueberries and raspberries in particular among the berry family. Garlic is excellent for decreasing inflammation. Green teas. The polyphenols in green teas are believed to be anti-inflammatory. Pomegranates have excellent polyphenols as well. Ginseng. There are many different kinds of ginseng. The ginseng that are valuable in decreasing inflammation are variably called red ginseng, Korean ginseng, Panax, Asian ginseng, or KRG. If you're getting a different kind of ginseng, it's not been shown to be as anti-inflammatory. Taurine is been shown to be very anti-inflammatory. You take about 1 gram of that a day. Curcumin, which is the active ingredient in turmeric, is believed to be very effective in cutting down inflammation, but you have to take it with pepperin, which you find in black pepper, or cyclodextrin coating, or a preparation called BCM95. Curcumin alone is not well absorbed. Glutathione is a very effective anti-inflammatory supplement. You have to take it with the N-acetylcysteine that we talked about earlier. Pycnogenol, pine bark, is a wonderful antioxidant, and the antioxidants are anti-inflammatory. Vitamin A, about 25,000 international units a day, can be anti-inflammatory. Vitamin C, a gram a day. You want to take that in divided doses. If you take too much at once, it just gets urinated out. Vitamin D3 is getting a lot of press these days and is believed to be anti-inflammatory, and vitamin E as well. Okay, so that's the trying to manage the inflammatory part of this process. Now let's talk about how you can change the neural misfunction. You want to decrease the response of the brain to these ocular irritants. Unfortunately, none of these have proven yet to be highly effective. People have tried dopamine anticholinergics, GABA. These things have not proven uniformly to be highly effective. Deep brain stimulation has been somewhat disappointing for benign essential blepharospasm, more helpful for Parkinson's, less helpful for benign essential blepharospasm. The shack drugs, as we call them, the benzodiazepines, they're called shack drugs because at lower doses they are sedative, then they're hypnotic, anticonvulsive, and finally, if you take too much, they induce coma. These can be helpful in decreasing the responsiveness of the brain. And it's interesting, I was lecturing to a whole bunch of patients with Mage syndrome, and I said, how many of you folks have tried the benzodiazepines? And everybody raised their hand. And I said, well, how many of you are still taking them? And I would say probably about a quarter of the people raised their hand. And I said, well, so for some people, they're helpful. And one guy stood up and said, you know, I don't really think they're helpful, but they help us not care as much about the blepharospasm. So maybe that's the case, I don't know. Artane has been used. This is an anti-Parkinsonian medication, and for some people this has been helpful. Behavioral training, so learning certain head positions or gaze positions for some people is very helpful in controlling their blepharospasm. Neuroplasticity training. This is an alternative therapy. I would not argue with somebody that said it helped them. In my experience, like acupuncture, acupressure, it's not been uniformly helpful. I think occasionally a patient will come in and say it's helped them. Humming, singing, and speaking. This is very effective in blepharospasm. There's a connection between the eye and the mouth. We don't fully understand it, but you'll recognize that every woman who puts on makeup opens her mouth when she's putting on her makeup. And we have other indications that there's a connection between the eye and the mouth. There are certain conditions where you'll have a blinking that occurs when you move your mouth. So a lot of blepharospasm patients will tell me that when they hum, they sing, or they speak, their blepharospasm decreases. And there are sensory tricks where if you press on a particular place in your forehead or your face, the blepharospasm decreases. We have several patients who come in with a tennis ball or a golf ball wrapped. They take an ACE wrap and they wrap it and put pressure on a particular place to stop their blepharospasm. And there's this wonderful device that I recently discovered, press up, that I believe is made in the UK, where they have hooked this little ball onto the glasses. And so if it can reach your sensory trick area, that can be very effective. You can just hook this on your spectacles and it can put the pressure and stop your blepharospasm. Prism spectacles can also be helpful if you find that a particular way that you hold your head, either up or down, is really helpful in diminishing your blepharospasm. You can get these glasses that bend your light 90 degrees or some percentage of that. And so you can maintain a particular head posture but see in a different direction. And these are widely available on the internet as well. You can get them from Amazon. The FL41 lenses, this will decrease the signal that comes into the brain. Some blepharospasm patients find them really helpful, and they come in a myriad of different ways. You can even get them in contact lenses these days, but you can get them on clip-ons, you can get them in moisture chamber glasses, you can get them in sunglasses or regular glasses. This is kind of an interesting thing that I've had a couple of patients use. They have little low-level lights they hook onto their glasses, and so it doesn't have as much glare from other room lights, and so they can still read very comfortably with these with a low-level illumination. And you can get all kinds of side glare protection. Again, if you can imagine something that will help you, somebody has probably made it out there, and if you search around a little bit on the internet, you'll find it, and most likely it's available on Amazon. Okay, so now let's talk about the fourth part of managing blepharospasm, which is really controlling the response of the eyelids to the brain. So decrease the ability of the body to respond to the brain's misdirection. There are these things that you can have custom made for you called crutch spectacles. They can take your glasses and then you can put these little wires on them that hold your eye open. Patients ask me, well, how will this allow me to blink? When we blink, a forceful blink, the eyeball rotates up underneath the eyelid. And you can blink if you're holding the eyelid open by the eyeball blinking under the eyelid. We have a number of patients who get good control of their spastic blepharospasm. There are two different kinds of blepharospasm, and I didn't really know when to put this in the lecture, and I'll put it in a couple different places. There's this spastic component that looks like this. There's active spasming of the eyes, and if it comes down into the face, it's Meige syndrome, and if it gets into the vocal cords, it's spasmodic dysphonia. Then there's something that was called apraxia, and it's really a bad name. It's a pseudoapraxia, and it looks something like this. I just can't open my eyes. Well, it turns out that that is really the same process. It is the same contraction of muscles, but it's only in the pretarsal orbicularis. We'll talk more about that. When that happens, this muscle here that has the normal blink is firing, and it won't allow a relaxation of the normal blink. And so sometimes you'll get Botox and it'll take out the spasm, but you'll still have that pseudoapraxia. And if it's a very weak pseudoapraxia, you can buy these dirt cheap eyelid trainers from Amazon. They were designed for the Asian patients that want to create a second crease. They're very thin plastic, they're not very strong, but if the pseudoapraxia is not very strong, these are really cheap. They're like $10 or $15 on Amazon. Okay, now we come to the botulinum toxins, which is the real way that we stop our eyelids from responding to the misdirection from our brain. We talked about the things you can do to help yourself. Now we're talking about the things with botulinum toxin that you can do to help your doctor help you. You know yourself much better than your physician can know you. And so the more information you can give your doctor, the more they can tailor the treatment for you. My first piece of advice to you is to keep copies of all your injection treatments and maps. If you go from doctor to doctor, you want to have this information. Sometimes the doctor will not have ready information available to them about what you've done before. And it's very helpful if you keep a copy of all of your injection maps. Keep it in a 3-ring binder. Keep your medical record yourself. My second piece of advice is to insist on drawn maps from your doctor. A lot of physicians will say, oh, I put 3 units in the lateral orbicularis. As Dr. Murdoch told you, the lateral orbicularis goes from the brow down to the orbital rim. I don't know what that means. And they may know what it means, and that's great for them. But if you want to take that information to somebody else, it's impossible to interpret it. I give a lecture to, or a training session to people who want to learn how to be better at cosmetic toxin injections. And frequently they'll say, oh, I do the 4 points in the glabella. 4 points in the glabella. That's different for everybody. The dose is different for everybody. So there's no specific pattern that translates from physician to physician or patient to patient. And just because a particular physician is used to always doing a particular thing, that doesn't translate to anybody else. So insist on drawn maps. The other thing is if the doctor doesn't allow, their electronic medical record doesn't allow them to draw, you can still bring them blank papers like this and ask them to draw on that paper that you keep yourself where they put their injections exactly. In our practice, we draw a map like this and we tell you exactly how many units we put where, so it's easily understood by anybody. So if your doctor doesn't have an electronic medical record that allows them to do that, bring the papers with you and ask them to make markings on the paper so anybody can understand it, and keep those. Avoid changes in chilling and anesthetic. These things diminish the toxin effect. What does that mean? So we did a study a while back where we took blepharospasm patients and we treated half the face with anesthetic and then put a different cream on the other half of the face. And because people can tell a difference between anesthetic and non-anesthetic, we also iced down both parts of the face, and hopefully that made a difference so that they weren't able to tell as well. Then when they came back, maybe they forgot or maybe they didn't forget which side had the anesthetic, we asked them which side did better. And interestingly enough, 12% of people said that the anesthetic treated side did better, and almost 90% said, wow, the side that was treated with placebo did better. Now, I don't know if they could really tell the difference and if they really remembered, but the point is that they believed it made a big difference. And we did the same thing in cosmetic patients. Again, very similar. 10% said, hey, it was better on the anesthetic treated side, and 90% said it was better on the non-anesthetic treated side. And that's among the cosmetic patients. So why would that possibly be true? Well, as Dr. Murdoch explained to you, there's a heavy chain and a light chain in the botulinum toxin, and there's a zinc metalloprotease connected to the light chain. So the light chain cannot do its job without zinc bound there. And if we look at, again, what happens here, the acetylcholine is released from the nerve, and those little molecules then tell the muscle fibers to contract. And what botulinum toxin does is it interrupts that process. So here are those heavy and light chains that are coming, and they're binding to the nerve. The binding to the nerve is dependent on the firing of the nerve. Anesthetic will decrease the firing of the nerve, and it will decrease the binding of the toxin. What doesn't bind to the nerve within the first 30, maybe as long as 60 minutes, is destroyed by extracellular proteases. So it's important that it binds to the nerve as quickly as possible. And if you've got topical anesthetic on, it will decrease the rate of that happening. Then once it binds to the nerve, it has to be taken up into the nerve. And that process is dependent on both temperature and on the firing of the nerve. So if the anesthetic is decreasing the rate of firing, it will decrease the rate of internalization. And if you've chilled it, it will decrease the temperature so that you will decrease the rate of uptake. And again, if the toxin is sitting on the outside of the nerve, it is then amenable to being destroyed by those extracellular proteases, and you're not going to get the same amount of toxin. Okay, and then these light chains bind to the SNAP25 and inhibit the neural release of the acetylcholine. And remember, both of these, all of this function is dependent on zinc, either extracellular zinc, zinc outside of the nerve, or zinc inside of the nerve. There has to be zinc in either of those places, or the toxin will not work. That zinc metalloprotease is important. So The essential points from the biochemistry that we understand is that cold within the first hour of injection probably decreases the efficacy of the toxin. You don't want to chill before, and you don't want to chill after the injections. The anesthetics probably greatly decrease the efficacy of the toxin. And the big problem here is not, okay, so then we have to use more toxin. The problem is, how do you really control how much chilling? How do you really control how much anesthetic you're getting? So you'll have a tremendous amount of variability now from treatment to treatment. Moving the desired muscles, that is squeezing, contracting, probably increases the efficacy of the toxin within the first hour. Again, if you have no zinc in your body, you will have no effect. So why do we care about this zinc? The NANES 3 study that was done by the NIH back in the 1990s looked at 29,000 people. And based on this, they said 45% of the population consumed less than 75% of the RDA, the recommended daily allowance. And that's assuming that people were actually taking their dietary supplements. Half the population was consuming much less of the zinc than they should. If you were over 55 years, then you were especially at risk. And we're assuming that you were taking a dietary supplement, you were getting 100% of that total zinc absorption, which actually is not correct. Different zincs absorb differently. For example, if you get a zinc lozenge that's supposed to help you from colds, you get that from the CVS, that zinc is specifically designed to be a poorly absorbed zinc. It's a lozenge that sits in your mouth, and it releases zinc into the nasopharynx because zinc binds viruses and then it gets excreted. So the zinc is not absorbed. So the zinc that you might get in a cold lozenge is not well absorbed. If you take a dietary supplement that says 100% of the zinc RDA, 100% of calcium, magnesium, manganese, etc., you're not getting what you think you're getting because all of the divalent cations, all of the positively charged elements compete for absorption. We'll talk about that again in a second. So it's interesting. If you look at the bottle of botulinum toxin, it comes with an insert. And this particular insert comes from the cosmetic Botox, which is exactly identical to the medical Botox. And if you look at the insert, there's this table 3, and that says, here's the Botox cosmetic. And let's look at what the investigators thought when they looked at patients under the age of 65. And they said it at day 30, 81% of the patients had a benefit. If you look at the patients over 65, they said 17% had a benefit. And the placebo was 22%, not much different from the folks that were getting Botox. So based on this, they said Botox is not recommended for people over 65. Why would that possibly be? We give Botox all the time to people over 65. Remember, the NIH said people over 55 are much more likely to be zinc deficient. So how can we know who is low in zinc? The urine levels are not predictive of tissue levels. The blood levels are not predictive of tissue levels. Tissue levels must be obtained by biopsy, and that changes within days. So you'd have to biopsy your eyelids every time you're going to get a botulinum toxin injection to know whether you needed zinc or not. So here are the factors that adversely affect zinc levels. Age, as we said, over 50 years. Increased metabolic demand, people who are pregnant, anybody who has an acute illness, people have malabsorption syndromes, so frequent diarrhea, liver disease, frequent laxative use, competing divalent cations, as we said before. We'll talk about those in a minute. Any kind of gastrointestinal illness, such as something called sprue, ulcerative colitis, Crohn's disease, these will all decrease the zinc absorption. Dietary factors. Low zinc in your diet, typically vegetarianism. I told you you ought to be a vegan if you want to decrease inflammation. Well, if you're going to do that, you have to make sure you're getting enough zinc. That's why I told you should get a dietitian or a nutritionist to help you out. Red meat avoidance will be low in zinc. High phytates. Phytates are a chemical that binds zinc. As a quick aside, soy is very high in phytates. And if we look back at Asian cultures, ancient Asians who grew soy and those that grew rice, soy is easier to grow than rice. The soy farmers ate their soy. The rice farmers ate their rice. The soy farmers all died because the phytates that are heavy in soy bound their divalent cations, and they starved to death. Rice is extremely nutritious. In fact, there are many cultures in the world that feed their infants rice water. So they cook their rice, they pour off the extra water, and they feed that to their children, their infants, instead of formula if they can't get formula, and the infants thrive. Alcohol will decrease your zinc. Casein, as we talked about before. Phosphates in all soft drinks. So if you're taking zinc, you want to be not drinking soft drinks at the same time. And EDTA and E391 are very common preservatives that bind the divalent cations, in particular zinc. Dietary supplements, poorly absorbed forms of zinc, as we said, the lozenges, high fiber, vitamin A. Now all the divalent cations that compete with zinc, if you take them at the same time, you will not absorb nearly as much of these divalent cations as you think. They are all competing. Iron, calcium, copper, magnesium, manganese, these all compete with zinc and with each other. So phytates bind zinc and prevent its absorption in the gut. And you can find this table on our website. You can also find it in this video. What we've done here is at the top of the table, we've put the foods that are higher in zinc, and at the bottom of the table, we've put the ones that are lower in zinc. At the top of the table are the foods that are lower in phytate, and the bottom of the table, the foods that are higher in phytate. So you want to eat more oysters and turkey. Turkey is a great source of zinc if you take it without bread. You just eat the turkey. Soy, wheat, and seeds are very high in phytates and very low in zinc. If you eat 1/2 of a whole grain roll at the time that you're eating a large steak, you will absorb none of the zinc because the half of a roll of whole grain roll will bind all of the zinc that's in the steak. Is zinc for everyone? Sure, why not? Why not take zinc before you get your botulinum toxin? If you're low in zinc, you've replaced it. If you're not low in zinc, you're not going to get into a trouble with a short duration of zinc. So 92% of patients in our study, and then we tested patients that were difficult to treat botulinum toxin patients, had a 30% increase in duration. Over half of the patients said that they were significantly better than before taking zinc supplementation. Don't take zinc before your botulinum toxin if you're taking too much zinc already every day for some other reason. And if you're somebody who has taken a long time to figure out your injection pattern and you're happy and we've got it figured out, please don't change anything. Don't change the amount of zinc. Don't change your diet because it's taken a long time to figure out what was good for you. Don't screw around with that. Okay, how to take zinc. In our study that we did zinc citrate 50 milligrams a day for 4 days before and on the day of treatment. You can get zinc citrate from the pharmacy, from the Whole Foods store. You don't have to get anything fancy. You can buy tons of it. Some patients double the dose. Well, for 4 or 5 days, it's not going to hurt you. Some patients take half before and half later. Again, it's not going to hurt you to do that. I don't know why that would work, but some patients tell me it does. Take it without food or other supplements. Now, the problem is that zinc can be fairly upsetting to the stomach, so you want to be careful about taking it on an empty stomach if it upsets your stomach. Take it with turkey. Turkey is a great source of zinc, and as long as you're not taking it with bread, that's not going to have phytates in it. If you want to take it with other foods, consider adding phytase, which breaks down phytates. But it's hard to find phytase. And let me tell you that we came up with a combination of zinc and phytase, and we patented it. And I don't make any money off of what you buy and don't buy. I don't care. I leased that patent to a company that makes a commercial preparation that joins the two. So if you don't like eating a ton of turkey with your zinc and you want to take it with other meals because it's upsetting to your stomach, you might think about using that preparation. What influences botulinum toxin effect? Well, the toxin type, of course, does. It used to be that they were non-standardized. Now the FDA makes them very standardized. The toxin preparation, that is who is preparing the toxin. If they shake it up a lot, it will destroy the toxin. If you take alcohol and you wipe off the skin and you don't let it dry, it destroys the toxin. If you're using cold or anesthetic, it decreases the efficacy of the toxin, and it's very hard to standardize that. The injection placement, where you're getting injected, it makes a big difference. The toxin dose, how much you're getting. The toxin frequency, if you're getting it too frequently, it increases the dose. Toxin dilution. If you dilute the toxin, it spreads more. Some patients tell me that when they bruise, it dilutes it, spreads it more, it works better for them. So here are the different toxins. They're all diluted, how much we add to them. They come as a powder and we add a solution to them. All of them except for Myoblock. Myoblock comes as a solution. So if you add a little bit of solution, it's fairly concentrated. If you add a lot of solution, it's more diluted and it spreads more. The technique can affect how it works. So if you take an injector who's got a lot of experience, it's very reproducible. If they don't have a lot of experience, it may not be as reproducible. The amount of swelling that you have, your diet, and your post-treatment movement will influence the botulinum toxin effect. And then there are other factors that Dr. Murdoch talked about, such as medications. Insist on an individualized treatment program. You are different from everybody else. Not everybody gets treated exactly the same way. Here are two different patients, very different treatment patterns. It needs to be individualized to you. Keep a diary of dry eye symptoms and overall spasm efficacy. Don't just say, I couldn't open my eyes. I want to know why. So make a scale 0 to 3 or 0 to 10 and tell me about dry eye and spasm control. And I'll explain that to you in a minute. The diary helps to provide insurance treatment and that necessity, and that's important if the insurance company comes back and says you're just doing this for cosmetic reasons. And it helps to provide your injector with more information. This is how you keep a diary. You choose a scale 0 to 10 or 0 to 3, I don't care what you choose, and you then write on your diary how effective your treatment was in controlling the spasms. In this particular individual, they said a 0 meant that they had a very bad control, 10 meant that they had a very great control. And then they kept a daily log of how much control they had. Early on, they had very little control of their spasm. In the middle, they had great control. And toward the end, they started having problems again. They also would mark how dry the eyes feel. And in this particular individual, 10 was bad and 0 was great, the opposite of what they felt with the spasm. And they kept then a record. And early on, they had very little dry eye. Then they had a lot more dry eye early after the injection. Then it got better. And towards the end, they had no dry eye. Then you go through and you circle the days that were good, the days that you were able to function. And this individual picked days. And if you look here, well, they're not so dry and they're good spasm control. Those are good days. But here we have 2 days that they didn't have great control. What happened in those 2 days? Blepharospasm and Botox are not capricious. There is something else that affected, that impacted those days, and only you can figure it out. And the more you look at the data, the more you will be able to figure it out. And you'll figure out what you can do to improve your situation. So this is spasm control. And I know we're going a little bit tight on time here, so I'm going to rush through this kind of. Here's time and days, and this is the amount of spasm control. This is an excellent effect, 100% spasm control. You get the Botox injection, it gets better. Spasm control is great, and then the Botox wears off. So here are a bunch of different scenarios of the information you might give your doctor. This is perfect toxin dose and placement. This tells us that there's not enough toxin, or there's some other influencing factor that has decreased your ability to control the spasms. This tells me that there's perfect toxin effect, but there are other intermittent factors day to day that affect the control of the spasm. And this is a perfect toxin dose, but maybe you're getting too much effect early on. And so maybe you need to spread out the duration of your treatments. And this would be wrong placement, spread, that is the toxin got up and made a droopy eyelid, or you have pseudoapraxia reveal. What does that mean? You knock out the hard spasming, and then you realize that the eyes don't open well because there's also pseudoapraxia. So that information is very valuable to your injector. The same kind of information is important about dry eye. So in this second case, there's severe dry eye not related to the toxin, or not enough toxin at all, or frontalis antagonist blink syndrome is playing a large role. Again, too much toxin effect, blink inhibition, but there are mitigating factors. And these are kind of the opposite of the spasm graphs. Too much toxin effect, videos in the middle in this kind of a situation that you send to your doctor would be very helpful. And here's a perfect toxin treatment with inhibition of frontalis antagonist blink syndrome. You want to take the two pieces of information, spasm control and dry eye, and merge them together so we get the best functional effect. Remember, the more we control spasm, the less we blink, the more dry eye problem we can have. So it's a very fine balance between those two. Then the question is, how often do you get treatment? This is maximum treatment. That's duration C. This is the time for the toxin to take effect, 4 to 7 days for most people, some patients 1 day. And here's the toxin effect wearing off. How often should you get your Botox injections? Well, here's the formula. If B equals A, it wears off at the same time that it comes on, then that's 0. It's just the duration of time that it has maximum effect, because while it's wearing off, it's also increasing if you're coming that frequently. If B is much longer, then you're going to subtract A from that to get the frequency of treatment. You know, so many patients will say, I'm just going to come in every 3 months or something. That's my C. The problem with that is that you get this period of B that may be 2 or 3 weeks, and you get the period of A that may be a week. So now you've got a month where you're not getting good effect, and it takes you a week to get in to see your doctor. So it's more than a month. So a third of the time you've got poor blepharospasm control. You want to get into a regular pattern of treatment based on this kind of a model. Inject as often as you need it, not every 3 months. Some patients come in every 6 months, some patients every month. Take and send videos. Videos are very helpful to your doctor. Document for insurance helps the doctor to help you. We can run these slow motion and we can see which muscle groups are specifically spasming that we've not controlled. And it's a much better assessment than the 5 minutes that we get talking to you in person at one particular time. Please, if you're going to send videos, keep them short, 1 to 2 minutes. Nobody's going to watch a 15-minute video. And we want to know at 2 weeks, that's when the botulinum toxin should be having its best effect. We want to know what's the best and what's the worst. The best tells me, okay, you're still having spasms. We need to do more treatment. The worst, did we miss something? And at the best, maybe we find out we need to do some surgery. We want to see you at the end of your treatment cycle when it's the very worst. Again, otherwise all I get is 5 minutes. If you take a long video and you chop it into little pieces and send me 1 minute of a video, I can really get a lot of information from that. And send your videos in advance of your visit. Dr. Murdoch talked a little bit about the musculature here, and I want to talk just a little bit more about that. The frontalis muscle she's talked about, the orbital preceptal orbicularis, and the pretarsal orbicularis. The B section, the orbital and preceptal orbicularis, is involved in the hard crunching, the spastic component of blepharospasm. The pretarsal orbicularis, what was called apraxic, but which really is pseudoapraxic, is involved in the inability to open your eye because it's the part of the eyelid that is doing the normal blink, and you just can't open your eye So the spastic is the A and B portion. The pseudoapraxic is the C portion. And you want to be treated where you are having a problem. And your muscle problem is likely to be very different from the next person. The pretarsobacularis injections are for the patient that has pseudoapraxia. And these are these tiny injections right by the eyelid margin. Pseudoapraxia is the most difficult to treat because it is the thing that gives you the normal blink, and we want to try to preserve that as much as possible, but it's also the part that won't let you open your eye. And you have to do multiple injections because the nerve innervation is different along the entire eyelid. Okay. If you have a pattern that works, don't accept that. Don't do it that way when you go to see another doctor. It's okay to try a new pattern, but be sure that they're willing to go back to your pattern that worked. Okay, so in summary, take your own care into your own hands, maximize your eye comfort, be aware of what impacts your blepharospasm, be creative and innovative in your care. Don't wait for your physicians to figure it out. Help them, give them the essential data, and finally, remember happiness is a choice. Take control, free yourself, you are not bound. All right. We're running a little bit behind, but I want to answer some of these questions that were submitted to us in advance. I'm going to ask Dr. Murdoch to answer her questions that were given to her first. So Dr. Murdoch, perhaps you can jump in here.
Sure. All right. I've been trying to answer your guys' questions along the way as well in the chat. I know a lot of them have been submitted. And just again, we will answer more questions that will be published in the BEBRF newsletter. So let's go through. Okay, first question. What is the best way to treat dry eyes if your eyes don't totally close when you sleep? Good question. First and foremost, lubrication. So the dry eyes happen because your eyelids aren't completely closing your eyes. They are partially open and they start to dry out because of the exposure to air. So lubrication is the first and foremost best thing in the form of artificial tear ointment. This is over the counter, comes in various different brands. As long as you goop up your eyes with some ointment, it'll help to protect the evaporation of the tears. Moisture goggles. Dr. Soap Parker mentioned moisture goggles that are also helpful if you could sleep in them. They also keep moisture onto the eyes. An eye mask could possibly keep your eyes closed and covered. And then optimize your environment. Humidifier in the room. Try not to have any overhead fan and wind in the room. If you do have a fan, get a standalone, point it away from your eyes. That'll also help. Are there possible bad side effects that can occur from long-term use of botulinum and toxin injections? The short answer, no. These injections have been used since 1987, so for decades, they are still very common. They're still showing that they are safe and effective. What is the latest information on using marijuana for blepharospasm treatment? This is to be continued. While marijuana does show promise, there are scattered different case reports and case studies looking at different marijuana cannabinoid products for the use of blepharospasm. There are some new larger studies that are about to be initiated now to really delve into cannabis and blepharospasm with more patients in a more randomized trial to determine safety and efficacy. Are there long-term side effects from taking anti-anxiety drugs such as lorazepam? Short answer, yes. Long answer, there are many different side effects with long-term use. Most of these are time and dose dependent. So the longer you use them, higher risk of these effects. The higher dose you use also increases these risks. So memory loss, confusion, lethargy, headaches, risk of addiction is a big one with the benzodiazepines. Impaired coordination, there is a statistical increased risk of hip fracture with long-term use. Fatigue, depression, nausea, vomiting. So be careful. If they're not working very well for you, try to back off. Think about these side effects. Many of the women I speak to say they had onset of blepharospasm after menopause. Is there a connection? Yes. Remember the whole dry eye blepharospasm cycle we keep harping on? Decreased androgens and estrogens can occur with menopause. This leads to decreased oil production and decreased tear production. More dry eye lowers the threshold for onset of blepharospasm and can also exacerbate pre-existing symptoms of blepharospasm. So yes, that can make blepharospasm worse. Are there dangers for other conditions to set in for those of us who suffer from blepharospasm? If so, could you mention things we should be on the lookout for? Dr. So Parker mentioned these as well. So MAGE syndrome, when the blepharospasm starts to come down around the face, the jaw, the tongue, causing muddled speech, spastic dysphonia and contraction of the throat, and then spastic dystonia and the inability to relax muscles. In terms of more systemic dangers or other conditions that affect brain body, not so much. Some doctors have recommended avoiding the use of erythromycin ointment. What is your opinion? Would you have any suggestions on using Inveltes for burning eye symptoms with rosacea? Erythromycin ointment is actually really great for rosacea, not for the antibiotic, but for its anti-inflammatory properties. However, it can lead to resistant bacteria. So again, we usually like the artificial tear lubrication that doesn't have any active ingredients in it to lubricate the eyes without using a antibiotic or like this loteprednol and Veltes, a steroid, because steroids also have long-term side effects like glaucoma, cataracts, etc. So the safest option, artificial tear ointment. Easy, safe, over-the-counter, cheap. And I'll send it back to Dr. So Parker.
All right. I'm not sure why this doesn't easily connect. Let me see.
We see your slides.
Right, but it doesn't advance. Let me try this. Screen sharing is stopped. Okay. Oh, I'm such a failure. Let's see. Screen share. Share. Let me see if I can get this to work.
So far looks good.
Good. Here we are. Okay. So a doctor I went to for injections used a vibrator on my forehead supposedly as a distraction. Instead, it had the opposite effect. Have you ever heard of this? Absolutely. We frequently will do things to kind of distract the patient, tapping on their forehead, vibrator under the chin. You know, it's different for everybody. Some people find these to be helpful. Some people find it to be annoying. So if it's helpful to you, do it. If it's not, ask them not to. I'm 94 and getting injections for 38 years with good results, but in the past year, Botox seems not to be working at all. Could stress be a factor for Botox not being as effective? Could it be my age? It's not really age. Absolutely, stress makes blepharospasm worse. And it may be a change in your diet. It may be a change in your environment. I have not recognized that increasing age is a problem. We did have a small subset of patients a decade or two ago that we would give them a Botox holiday, give them another toxin for a short period of time, and then come back to Botox, and that seemed to work. But in general, I have found in the last decade or so that I've not had people that became non-responders to Botox. So I would look at other factors that may be influencing that change. Two people I know say omega-3 fatty acids have led to great improvement in their blepharospasm. One even stopped getting Botox injections altogether, though he's taking hemp hearts and Udo's oil. So again, I think that you're managing the posterior lid margin disease when you're taking omega-3 fatty acids, and it's really important. It's really important to maximize your tear film. And if you're going to take omega-3s, I would think about taking the borage oil and the flaxseed oil, and I would take them all with the sulfonated protein. What's the current thinking on whether omega-3 helps with dry eyes or not? Again, I think it depends entirely on the individual. If you just take everybody in the room and you say, okay, take an aspirin, did it make your headache go away? And not everybody had a headache, then taking an aspirin is not going to be necessarily effective at anything. If you have people that have a specific posterior lid margin disease problem, an oil problem, then taking omega-3 will help with your tear film and your dry eye. Aside from possible dry eye improvement, are there any other therapeutic benefits of omega-3 fatty acids in blepharospasm and other dystonias? And the answer is nobody knows. I mean, there may be a neuropsychological benefit. Inflammation, omega-3 acids will decrease inflammation, but I think the most direct impact is on the tear film. For 8 years, my Botox injections have ranged from 2 to 5 months apart, average 3.5 months. In February, I was injected, and 1 month later began strict quarantine. 7 months later, I still don't need more Botox. What could account for this extended effect? Improved air quality? Absolutely. Absence of general community interaction? Well, it's not going to interact with people that I think is the problem, but if you're going outside and you're in the cold grocery store or you're driving, these things can all cause more of a dry eye problem. Increased attention to hand sanitizing and washing, I don't think that has an issue. So I think the answer is stress. Stress can make it either better or worse. If you find it more stressful, then your blepharospasm will be greater with this pandemic. If you find it less stressful to be home, then it may be better. Eye irritants in your environment absolutely will make the problem worse. And your diet may have changed if you're staying home more. So that may be having an impact on how your botulinum toxin is working as well. Have you seen this with other quarantining seniors? I've seen both. I've seen some people whose blepharospasm is much better, and I've seen some people whose blepharospasm is much worse. Is neuroplasticity therapy effective for blepharospasm? As I said, it is an alternative therapy. I think I may have had one patient that said that neuroplasticity training was helpful for them. I don't think that in general for most people it is, but if it's good for you, I can't argue about that. If you try it and it's successful, absolutely continue it. I've had both spastic and pseudoapraxic blepharospasm for 5 years, partial myectomy in 2017. Spasms stop, but the eyelids continue to close. So it sounds to me as though the forceful contracting orbicularis, the preseptal, preorbital muscles have been removed, but the pretarsal orbicularis was not removed, so you're having more pseudoapraxia. Ptosis repair in January had no help. So again, the pretarsal orbicularis is not assisted with ptosis repair. You've got to target that muscle right above the eyelashes. Botox injections every 3 months, no help. It depends. If the Botox injections are to the pretarsal orbicularis, well, that's what you should be treating. And if that's not working, then maybe you need a pretarsal myectomy. What else can I do? You can think about pretarsal myectomy. You can also think about these eyelid crutch spectacles, so that if the pseudoapraxia is the residual problem, it may not be strong, and you may be able to hold your eyelids up with those crutch spectacles. Does BEB ever spontaneously disappear? I've had one patient who said it suddenly went away. And I've treated hundreds and hundreds of patients where it has not. I was given gabapentin for pain. At a higher dose, my MAGE and eye spasms got much better. Any information about this? So gabapentin is a neuroleptic. It slows down nerve conduction. I would not expect that to be a universal therapy for most people, and indeed it's not. If your balance of nerve contraction or nerve stimulation and muscle contraction benefits decreasing nerve firing, then gabapentin may help you. Again, it's so individualized, and I would say in balance, most people do not find a benefit from neuroleptics, but if it works for you, stick with it. Is there a connection between blepharospasm and rheumatoid arthritis? Dr. Murdoch touched on this. Yes, the autoimmune disorders create more dry eye, and we know the connection between blepharospasm and dry eye. Why do many blepharospasm patients have light sensitivity? It's because you have poor quality tears. Remember, if you have a poor lipid surface, that outer portion of the tear, you will be looking through oil droplets and there'll be a lot of glare. You won't have a smooth surface. So that tells me you probably have a posterior lid margin disease problem that's been unaddressed. I notice that when I'm on prednisone, my spasms almost disappear. Has there been a study done with this drug? And the answer is yes. The reason is you're decreasing the inflammation on the eyelids. I'm not sure that oral steroids, which have systemic side effects, are the best way to manage that. I would think more about local topical treatments to decrease your inflammation. Why does dystonia progress? Nobody really understands. The good news is that outside of the head, blepharospasm does not really progress. It may go down to the mage, it may go down into the throat, but it doesn't usually progress outside of the head. People report that I roll my eyes back in conversation. Is this related to my botulinum toxin injections? The answer is yes. If we're giving you enough toxin to decrease your blink, the way you blink is to roll your eyeball back up into your head. So yes, it's due to your botulinum toxin injections, decreasing your blink so your eyes stay open more. Do psychological issues such as trauma, abuse, or PTSD cause blepharospasm or cause it to continue? Yes, stress makes blepharospasm worse. Can drugs normally used for ADHD, such as Alderol, Ritalin, and Strata, lessen the symptoms of blepharospasm? And the answer, again, is it's different for everybody. There is not a universal response to these drugs. Otherwise, we'd be using them all the time. Again, if you've tried them and it works for you, nobody's going to argue with it. So if it's good for you, continue it. If it didn't work for you, don't continue it. Can long-term use of clonazepam cause blepharospasm? And the answer is unknown, probably not. A lot of patients will come to me with blepharospasm and say, I did drug X or this happened to me, and that suddenly turned on my problem of blepharospasm. Remember, we use the benzodiazepines in some patients to manage their blepharospasm. So did long-term use of clonazepam cause blepharospasm in you? Who can say? But typically that's not how we recognize blepharospasm being precipitated. What is the best way to make botulinum toxin injections less painful? So I've listed them here. Oral pain medications can decrease the pain. Distraction is much more effective typically than oral pain medications, and that was the vibrator on the forehead or tapping the hand or vibration under the chin. Small sharp needles help. Fast treatments, doing it quickly rather than slow injections with somebody who's a little bit less certain of what they're doing. You don't want injections that are too superficial into the dermis because those really hurt a lot, and you don't want them right up against the bone because those are quite tender. Ice and topical analgesics, topical anesthetics, those things can be helpful at decreasing the pain, but it makes the treatment less reproducible. How much are we chilling? How long are we putting on the anesthetic? Are we really getting the same effect every time? And so that's something that can easily change the reproducibility of your injections. Risks and benefits of long-term use of benzodiazepines. Dr. Murdoch already answered this question. Okay, well, I think we've run out of time here. I want to thank everybody for sticking with us. Dr. Murdoch, thank you so much for giving us the basics and for answering those questions as well. And I also want to thank the Blepharospasm Foundation for inviting us to talk, and all of you for sticking with us during this very long talk. Thank you very
everyone.
much.
Happy Saturday.
Thank you. Thank you. I have just a little bit more business. We have a lot of questions that have been submitted on the Q&A. And what I think we had intended to just go a few more minutes. I think perhaps it would be better, Dr. So Parker, don't you think, if we did these in writings and tried to cram in too many of these?
I think that would be an excellent idea.
Okay.
I also have been answering many of the Q&As during the session.
Awesome.
So
Awesome.
you'll find some answers to many of those that have brief answers to them.
Awesome. Excellent. Well, I want to thank the two of you so much. So much time and effort went into this and giving up your Saturday to do this for us. We're so appreciative. It was a fabulous educational talk. Thank you so much. I just have a couple of more things that I want, where am I here? Here we go. To share with you for things coming up in 2021. We are having our 40th birthday. We were founded in 1981, and 2021 will be 40 years for the foundation. So all year long, we're going to be doing celebratory things commemorating that. In addition, we will be unveiling an entirely new website. The website that we have is a very good website for information. The new website is going to contain all that information, and it's also going to have a lot more. And then finally, mark your calendars. The symposium this year was supposed to be in Philadelphia, but it got postponed, not canceled, postponed until next year in Philadelphia, October 8th and 9th in 2021. Dr. George Billick will still be the program director, and we'll be sending out a lot more information between now and then. Hopefully, the pandemic will back off, go away, be subdued by then. All right. Thank you all very, very much for attending this webinar. I hope that you got a lot out of it, and have a nice rest of your weekend. Bye-bye.